Good evening. Welcome to the April 10th meeting of the Washington Township Healthcare District Board of Directors. If you'll stand with me for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Catherine, can you call the roll, please?
Director Nicholson.
Present.
Director Stewart.
Present.
Director Danielson.
Present.
Director Eaton.
Present.
Great.
Director Wallace is away.
Thank you. We have two educational sessions tonight. Nancy, could you introduce our first distinguished speaker?
Yes. It's my pleasure to introduce to the Board of Directors Kimberly Alvari. She's our Director of Food and Nutritional Services. She received her undergraduate degree from Cal Poly in San Luis Obispo, graduating magna cum laude. Her postgraduate work was done at the University of California in San Francisco, where she was named the Bay Area's most outstanding dietetics student. Her early professional career as a registered dietitian includes positions at the University of California at San Francisco's Medical Center and as a consultant to Home Health Plus. Her years at Washington Hospital began as a clinical dietitian with a focus on critical care patients. The last 10 years have been spent in management of the clinical staff and most recently as our food services director. She's a member of many professional organizations, including the Academy of Nutrition and Dietetics. And with that, I'd like Kimberly to make her presentation.
Good evening. I'd like to thank you for having me here this evening. When I was growing up, I had a fourth grade teacher tell me that when you grow up, you want to make sure that you pick a job that you really love. Something you get up in the morning, go, great, time to go to work, versus, oh, I got to go to work. I did listen to that fourth grade teacher, and tonight I want to thank you for giving me the opportunity to come here to share with you some of the information that I love about the work that I do here at Washington Hospital. More specifically, the automation of the food delivery system with a web-based application known as Seaboard. Seaboard will be the tool and the nutritional prescription to improve nutritional care here at this hospital. Evidence-based research has long shown that good nutrition, not just green apples and good food, affects the outcomes in terms of patients' positive outcomes like, for example, decreased lengths of stay, decreased infections, and improved wound healing. So tonight, what do we have on the menu? I wanted to set the table. Seaboard's going to go live. This application will go live in July of this year. So in getting ready for that and during the development of that, we had some time to start to work on getting ready for what changes it would bring and how we would handle that change. So we started with looking at how we would set the table and get our service in order for the new type of service we'd be providing. We also looked at the current diet office operation and how it would change as we move into the Seaboard operation. So I'll share all of that with you this evening as well. So setting the table. As a new director of the Food and Nutrition Services Department, I started to look at how we defined the work that we did within the department. We had a vision, but I wanted to make sure everybody was on board with that. So I started to talk to each of the employees and ask them about what their vision for the department would be. We knew that setting that vision would help us align the employees, energize them to work, and held us accountable to what desired outcomes that we really wanted to get when Seaboard came along. The mission was simple. Patients always come first at Washington Hospital. Every patient, every time. We wanted to make sure that every encounter that we had with the patient happened, and it always happened. The quality patient experience does not happen by accident. It happens as a matter of design and intelligent effort, and we were going to put in that effort. Serving up excellence. Patients at Washington Hospital have always come first, safety's always come first, and the customer service we provide has always come first. But we started to think about that a little more as we started to move closer to our Seaboard project, and we decided, what could we do with that? We looked at some of the things that are happening at Disney, and we looked at a lot of different things, and we wanted to make sure that what we felt in our heart was translating to the patient at the bedside, that they would hear the words that we felt in our heart, and what would those words be. We talked about the work that we did. I sat down with the employees in the department, and we had small meetings, and I talked about that every job in the hospital was mission critical, that anything that you did that helped the outcome was important, that food service delivery was mission critical. I actually shared my favorite story story with them to try to drive home the point. I told them that there's a young man sweeping the floor at Cape Canaveral one night, late at night, and another man leaving his office, and he looks at him and he says, "What are you doing?" And the guy sweeping the floor simply looked back and said, "I'm helping put a man on the moon." I wanted to make sure that that our employees had that connection to that mission, so we talked about that. The other thing we did besides defining our culture is we started to do things differently. We spent time in the department having meetings every day talking about how we would get ready for our patient care. We started daily huddles, sometimes twice a day. And my favorite part of the huddle is how we leave the huddle. We gather in together just like a team huddle. Everybody's hand comes in and I said, "What are we here for?" We do a count of 3 and we break on a resounding answer for patients. Addition to that, we put into place a 10-foot rule. We figured, well, if we were in within 10 feet of anybody, they would probably see us. And so we would let those people know how we felt in our hearts about that. We would give them a smile or a kind word. So we practiced all of this every day. So now that we know, what we were practicing, we had to look at what are we doing in the office and how is it going to change. So I'll give you a little background in the current diet office operation. The current office runs on a McKesson order management system with a business objects application. Both these applications are not specifically designed to really run the food service operation. It's pretty laborious. We have 4 printers, 8 separate trays, 3 different colors of paper so we know what kinds of orders are coming in, 2 sets of labels, and 1 copier. Additionally, we have lots of RANs. We keep all of our patient information in these RANs, these colored RANs that you see here on the right-hand side of the screen. That's where we move people around when they move their rooms and their diet orders come in. All the ADT, the information about the patient comes in. Then we have additional RANs that go to the dietitian because she needs to house all of the patient preferences and their cultural and their religious and all of the things that they like about eating and the diet order from the physician. So we have a lot of RANs down there. These are the diet orders that we run. We run a lot of diet orders to make the operation happen. At the end of the day, we put out 500 to 600 meals, and we service about 25 different tube feedings. These are the different reports. You understand when we print a report, like any report, it's pretty much obsolete the minute it comes out. So we spend a lot of time then as information comes in, updating those reports manually, putting the information down that the doctors are sending through in the orders. We also we've talked about some of the RANs. You'll see a pile here on the right there of some profile cards. That's where all the information about the personal information about the patient in terms of what they like to eat or don't like to eat, or everything gets stored right there. And the diet order. All of those go into the RANs that the dietitians carry. We correct those menus. We send up our menus in the traditional tray line that we have right now. We send them up a day in advance, and that's pretty typical for a hospital that operates on a traditional tray line, to send up menus a day in advance. So the menus go up, we collect them back down, and we have somebody sit. It usually takes about 4 hours to hand correct those 500 to 600 menus. All those menus then get transferred back over to the office where a manual tally that takes about 4 hours happens, where the different portions and amounts of foods are hand tallied so we can get ready for production. Why Seaboard then? Put a little operational assistance into the department. Seaboard is a web-based mobile meal ordering application. You can use it with any web browser. You have a choice. We can do it staff assisted, or people can call down. Family members can even call from outside the hospital and let us know what their mother would like to eat that night for dinner, and we can take care of that. We can start with many different versions of the operation. It says room service, and it's a choice. There's multiple functionalities within the system. So it gives us a lot of opportunities to meet the needs of our patients here. So again, this is a lot of information, but I'm going to focus on the stuff that's in the bold there. Improve patient safety. We're going to get real-time information when diet orders are changing, allergies are updating. That's going to be coming across to us immediately. There's not going to be any manual transferring of information and moving it around. We're going to increase patient satisfaction. Right now, we're sending our menus out a day ahead in advance because we need to get them back, correct them, get them tallied. We're going to be able to do closer to real-time ordering with our patients and get menu satisfaction and patient satisfaction right away. We're going to know what people want to eat, and we're going to get that to them. We're going to improve their nutritional status. When people get to eat what they want to eat closer to their mealtime, they're going to be able to be nourished better. Support an efficient work process. The process that we have is, while it has some automation to it, it's a very, very manual system. I think you saw the 26 reports. So we're going to be able to improve the workflow throughout the whole department with how we're getting this information coming to us. We'll be able to control food costs, and that comes from when you plan 2 days in advance for your food and you have to make your tally and make your forecasting. Traditionally, what comes with that is an overproduction of food. When you know closer to mealtime who wants what, you're able to just plan for that and not overproduce. We control the material costs. We have a lot of paper, a lot of profile cards, a lot of RANs, a lot of things coming that we have to manage, pieces of office supplies and things that we need to manage. So we'll be able to bring those costs down and be able to take care of patients better with what we do. So room service choice, again, it's the name and it's the functionality that it offers to this hospital to have in there. It's mobile, it's easy to use, you get real-time updates, and it's really flexible. It's role-based design, and what I mean by that, if you look on one side, you'll see menu select on the right side there, and on the left side you see the on-demand call center. That allows us to move throughout the functionality. How we see using that here initially is that we'll probably be on the menu select with a traditional tray line running, but we'll change away from the patient menus. We'll be going up to the bedside and using devices so that we can order entry any of the menus that patients want right there at the bedside, get those in. They come in right into the menu select. The on-demand side would be for patients calling in, families from outside. We're going to go ahead and use some of that functionality right now because we see a need for it and we can use that very easily. Room service choice, again, we're going to put people, that's why we were spending a lot of time thinking about, how we, what we do when we deal with our patients, because we're going to put a lot of more boots on the ground. We're going to move some of the boots that we have downstairs, no new boots, but more boots upstairs. We're going to get in front of those patients because we think if you're fighting to get well or if you're in for the fight of your life, that you want as many boots on the ground as you can get on that medical team. And we think getting right to the bedside means better nutrition. So we'll be taking those orders and we're going to be able to then focus on patient-centered care. We're going to be able to talk to the patients right at the bedside. What do you feel like eating? What works for you? What doesn't work for you? And I'm going to show you some of the functionality that when we get to the bedside, what we're able to do with them. So again, real-time updates, that's a big thing. You can't feed people if you don't know what's going on. Menu selection actions, I'm going to show you a little bit of that on a little bit of screenshot I have. Totals for the day, calories that they're eating, their goals that they need, automatically adding supplements that we want, quick and easy ways to add foods, take them off, put them back on, change the quantity. And a private repository of the patient's nutritional needs. Nothing gets more personal than that, to be able to have a very private repository that we keep here. When you come back, we know you intimately. We know what you like to eat. We know what your preferences are. We know what your cultural needs are. And we also know this is how personal it gets in Seaboard. If you like to have 2 creamers with your coffee, every time you drink coffee, we'll know that in your personal diet and every time it comes up. If you want to have coffee cake with apple juice, you tell us that, and every time coffee cake comes up, you're going to get apple juice. Whatever it is that's your personal desire, we're going to know that. We can actually put your personal meal plan in there and work with that when we start to fill the prescription from the physician. It doesn't get better than that. Okay, filling prescription. Again, working in the traditional system that we have right now, we work in absolutes. We actually, when we get to the bedside, because we don't have granular data and access to that, we have to kind of say, it's a renal patient. You can't really have so many potatoes. We're going to have to, we're going to have to pick a different choice. Seaboard, all of the data in there that's entered for the food and our menus that we provide is tied to the USDA database. So we know how many grams of carbohydrate, how many grams of protein, how much potassium. So at any given point, we can negotiate how to fill that prescription at the bedside with the patient based on what's going to help them best. Seaboard and our farms, and you wonder, what does Seaboard have to do with our farms, and what are our farms? Our farms are this. We have gardens here at the hospital, right out at the heliport. We can't get enough produce out of that to feed all the 500, 600 menus that we fill a day. So what we've done is we have a vendor. We work with our vendor and we work with a local sustainability produce group. Only 5 hospitals in Northern California are in that group right now, and that's a group of hospitals that want to put quality produce that's nutritional, organic, or the best option for our patients in front of them every day. So we make decisions on what we want with those 5 hospitals. Our vendor goes out to our local farms, Coke and Zuckerman's, and they grow just what we want. If I say I want so many strawberries all summer long, They'll grow strawberries just for Washington Hospital. So we love that. I love that because I don't have to drive the tractors out at those farms. I just get to, it's the next best thing. So that's a great part. And why I say that is our menus are designed with seasonal produce. And so all of our menu that's been built in there, all it says is produce, seasonal produce 1, vegetable, fruit. It doesn't define it. All it means is that when we get ready, we know what's in season. And you know Mother Nature, strawberries may be in season, but the rain last week took them all out. We're going to make a move to the best produce we can get, and we're going to drop it right in, and Seaboard's going to let us move it that fast. Okay, key features, I told you it's going to allow us to add up totals and everything for the day. When they're at the bedside, the far right there, you see all of the courses. It says courses on that. That's where the different types of menu items are for the patient. At the bedside, they'll be hit the different courses. You can see here on the far right the different types of food that fall under that course. Ones in red are ones that would not be offered or compliant to the diet. The ones in black would be. So they start adding up the totals, putting everything together. If it's going over potassium for this renal patient, arrows will start to pop up saying you need to make a different choice, because adding that cup of milk just put the potassium level too high. You need to make a different choice. You negotiate that right there with the patient, and then they're going to be satisfied the first time they see that tray, because nothing was taken off without their permission. Real-time sessions, we don't miss meals around here. We're going to be able to follow. We know when people are NPO. We know when they've parked diets with us. So we can track everything. You can see on the very far right all the different little indicators, patients NPO, patients that have diets in. So we're going to track that. Tailor the workflow, I said that. We can work from today, we can work for breakfast, we can work for next week, we can do it however the patient wants to do it. And in the end, patients are going to just get a clean meal ticket. At the end of the day, just what they ordered. All that they ever see is just what they wanted. We'll get that bedside order entry, and they'll get a clean meal ticket saying this is what you asked for, and we've provided it. Wait, there's more. We're going to know about the insulin alerts. We're going to know about calorie counts, supplements, infections, if there's an infection control issue with that patient, and alternative service. Do they need something different than anything that we need to provide for them? We can track that. Here's a little sample of the alert. It has the alert up there for insulin. That lets us know the patient's on insulin. Maybe one of the physicians is tracking carbohydrate counting, and we need to know that. So improved nutritional delivery, improved carbohydrate counting, insulin matching with pharmacy protocols, improved calorie count process, knowing what people are eating, and meal satisfaction the first time. So at the end of the day, there's a lot of technology that's going to provide a lot of service to this organization. But we know in the food service department, with the way we set the table, the way we looked at how we wanted to provide excellence to our patients, that it comes down to patients. The technology is great, but every day it's about the people that we take care of. Patients come first, every patient, every time, all the time. And that quality patient experience that we give to those patients does not happen by accident. It happens by all of the thought that's gone before the program that rolls out on July 1st. It's a matter of design and intelligent effort. Any questions? I love to talk about it.
Thanks. It's
Anything you
really,
want.
really exciting work, and as you know, I feel that nutrition is really one of the fundamental keys to good health and improvement here in the hospital. Washington Township is blessed, and one of its strengths is that we have such a tremendous cultural and ethnic diversity in our community. And I'm sure that represents a huge challenge for you. How does this system help you deal with that? And also, how does it help you deal with the patient who doesn't have English as their first language?
It has some options to move into some other language. It's not something we're going to be tapping in initially. We're hoping that the functionality that's going to be there is for patients maybe who don't speak English. If we can get to the bedside, we can always do some things where we can get information either on a translation phone if we need to. But basically, the family members are usually the ones we're going to contact. So I think the functionality to be able to talk to people and park those diets in there and let them call in if they're at their desk at home, at work. And they want to call and order mom's lunch, just call us up. Let us know what they want to eat. So we think that's going to to be a huge benefit to us. In terms of the cultural and religious, that's what we do every day. We have planned the whole menu and the backbone to this to address those needs for this community and make sure that everything that they need, the options and everything. And that's kind of the fun part, because when we start to look at that and you talk to people who've developed these kinds of systems, they don't have the same kinds of, look that we have at it. So we've definitely addressed that, and we have lots of options in there for those patients. We're very sensitive to that. So, yeah.
Great. I'm really proud of the work that you've done to work to move more of this activity to the bedside, improve the interaction with the patients and with the family, because I think that's going to make a lot of progress.
We're excited. I'm trying to
just-
contain myself.
Really good stuff. I look forward to your report next year where you tell
I
us
can't
when
wait.
you've given us
I
an
can't wait.
update.
Really, I
Yeah.
can't wait. There's going to be so much more. This is just the beginning. So
Great.
I appreciate your time, and I realize that maybe that your favorite job and what you love wasn't what I do, but what your fourth grade teacher said. But I appreciate it very much.
Great.
Thank you.
Kim.
Kimberly?
Pat, you have a
I have one question.
Oh,
One comment, one question. This is exciting. Food is important. People derive a lot of pleasure out of what they eat. So I think I'm really pleased to hear what you have to say. But I have one burning question.
good.
Have you found a replacement for that disgusting green Jell-O?
Oh, you know what? We don't have green Jell-O on the menu anymore. We don't.
Oh, good. I'm glad to hear that.
We don't have green Jell-O on
Thank
the
you.
menu. Yeah, we have found a replacement, I guess. Then that would be the answer. Yes, we don't have green Jell-O on there.
Oh, I'm so
Yeah.
relieved. Thank you very much.
Yeah. So,
Pat, I'm
And-
taking
yes.
note of this. I'm going to make sure you get a special serving.
that's it? With any
Thank
other
you very much,
questions?
Kim.
No, thank you very much. I appreciate it.
All right. We have a second educational session.
Before we move on to the second educational session, I just wanted to say that when you're a patient in the hospital, sometimes the only thing you have a choice about is what you're going to eat. And people should not underestimate how important it is to have somebody as enthusiastic as Kimberly running this department. She makes all of her employees understand that what they do for patients and on behalf of patients really does matter. And I couldn't be more pleased with her leadership. I think she's really stepping out there and embracing what's coming and getting her department ready to roll this out. It's fun to watch. Our second session stems from a conversation that occurred in our last board meeting around observation patients and what compensation from Medicare looks like, and also how it affects what patient responsibility is for their portion of the bill. And I've asked Chris to come back quickly and review this, and as most people know and understand, Chris Henry is our Chief Financial Officer. I don't think I need to introduce him beyond that, but this is a continuation of that discussion and the questions asked by the board.
As Nancy mentioned, I'm just going to have some brief comments on, one of the questions was, well, what determines whether a patient is observation or inpatient? And the second question I want to answer tonight is, okay, what does that mean from a financial standpoint, both for the hospital and the patient? So according to Medicare, observation should be considered when a patient is stable, does not meet acute care criteria, and if any of the following apply. Patient is stable and is expected to be discharged in 24 hours. If there will be more than 6 hours of treatment required, but the patient will be discharged. If the diagnosis of what's going on with the patient is unclear and the physician feels that will be determined within 24 hours. If there's a procedure being done on the patient that will require observation and the procedure is longer than 6 hours. If there are complications from an ambulatory surgery or procedure, or if the patient has not responded to emergency treatment of at least 4 hours. So those are the general criteria being used to determine whether a patient should be admitted into an observation situation. These are the following diagnoses that are considered candidates for observation. When this first started, this list consisted of 3 diagnoses. Rule out heart attack, asthma or COPD, and congestive heart failure. It has since grown to this, but in reality, there is no defined diagnosis that qualifies for observation. It really gets back to these first criteria. And if in the physician's judgment these criteria fit, then that patient is appropriate for observation. It is highly dependent on the physician's judgment and the documentation of that judgment in the chart, and is unfortunately rife because it's a judgment call for Monday night quarterbacking and second guessing. So what does that mean from a financial standpoint? This is the look at what it means for a hospital. What we did was we chose 3 observation patients with different diagnoses. We pulled the bills and we looked at what we got paid as an observation, what we would have been paid under an inpatient DRG. And as you can see, the payment difference under an observation, outpatient observation, is roughly half of what we would have been paid as an inpatient. Now, why this is important is because the patient is occupying an inpatient bed. They're up on the 3rd, 4th, 5th floor, acute care floors of the hospital, utilizing the same resources as an inpatient, costing the same amount of money, yet our reimbursement is roughly half because they're classified as an observation patient. Second question was, okay, what's the impact on the patient from a financial standpoint? I think Director Nicholson asked that question. Same 3 patients. Now this assumes that the deductibles have been met for the year, okay, or for the benefit period. So as an outpatient observation patient, the cost to the patient ranges somewhere between $550 in this group and $870. If they were outpatient or inpatients and they had met their benefit period deductibles, it would have been 0. Now, had they not met their deductibles in this situation, the outpatient patient responsibility would be roughly $150 added on to these costs. On the inpatient side, $1,184. So the answer is the impact, what's most beneficial for the patient, it depends. It really depends on the status of these deductibles. So again, very brief comments. This is highly dependent on physician judgment and can be second guessed in an audit situation, and does get second guessed frequently.
Chris, I don't want to muddy the waters more, but thank you for clarifying the issue.
Yeah.
What happens when patients, if they are brought into the hospital on an observation status, and then a diagnosis is established which requires further care beyond the 24 or 48 hours?
And then they are admitted.
Then that becomes an
There
admission.
was a point where we got paid for the observation days.
As a separate
and then the
payment from
DRG. That changed a couple of years ago, I believe, where now all we get paid is the DRG. It all rolls in to the inpatient payment, and those days are lost.
I think we need to explain what a DRG is.
Yes.
And that's like a case rate.
Yeah.
Okay, so if you're here for a specific diagnosis, Medicare has assigned it a dollar value.
Yeah.
And that's all that's reimbursed.
Yeah,
It doesn't matter how many days you're here or how much you use in the way of resources. It's just simply that.
It is a form of a bundled payment. DRG is diagnostic related group, and they grouped all the services together into one bundled payment.
So it's clearly advantageous to the hospital if a patient needs to be an inpatient to have them be an inpatient. In the situation where a patient is admitted under observation, what kind of decision-making tools do we use to help decide whether a patient should be an observation or an inpatient?
You know, I'm going to turn to Stephanie for that one because I'm not in the middle of the clinical piece of this.
Because that's a tough nut to crack.
Come
and
on
I
up,
think that's one we as physicians have trouble getting our hands around.
You're right, Dr. Nicholson. We do have criteria. We use a criteria called Interqual, and it's used by many other institutions. With CMS and Medicare, it's somewhat complicated because they don't just use one criteria. They use a combination of Interqual, they use Milliman and Roberts and their own criteria. But there is set criteria in terms of, why that patient needs to be here. There's something called the intensity of service. So when a patient comes to the emergency room, they can come in with CHF. But if they come in with CHF and you're not treating them with Lasix and you're just going to watch them and observe them, then that falls under observation. But if they come in with CHF, their vital signs are unstable, they have their blood levels are out of control, then we look to see whether they meet the criteria for inpatient. And it all boils down to documentation, because you basically have to tell the story of what's going on with that patient. What have you done on the outside that warrant that patient being treated on an inpatient basis? And it's not black and white, even though to CMS sometimes it seems really black and white, but to us, it all boils down to what's been going on with that patient, what are some of the issues, what have you tried as an outpatient, but it boils down to documentation. So we have had patients with those diagnoses that met the inpatient criteria. So this is where the case managers come in, they review the criteria, and oftentimes they will contact you and said, you admitted this as an observation, but this patient meets the criteria for an inpatient. So we do a lot of back and forth in terms of changing patient from inpatient to observation, and from observation to inpatient.
Thank you. Thank you very much.
Explain what CMS is.
The other point
We speak in acronyms. Please explain
Yes.
what CMS is.
so that's the Center for Medicare Medicaid Services. That's Medicare.
And they make the rules.
And they make the rules.
Around reimbursement.
Yes, they do. And, this might be better for the hospital on an inpatient, but that's not how the decision's made. The decision's made based on what's best for the patient.
Right.
And that's the bottom line. How we get paid is secondary to what's best for the patient.
Chris, I want to go back just a bit. I apologize, but I want to be sure I'm clear on what you said.
Yeah.
If a patient is admitted on a observation basis and then changes to an inpatient basis, there is no payment at all for the observation days. It just becomes inpatient after that.
Medicare considers that part of the services received as an inpatient at that point.
Okay, so
Yes.
the observation day then then is actually paid on an inpatient basis.
As an inpatient day under the bundled payment, the
Okay,
bundled fixed payment for that particular service.
all right. I misunderstood that, and I'm
Yeah.
glad to get that clear.
Right.
Chris, I have a question. In the beginning, when observations was first began, a lot of the diagnoses were of chronic conditions. And I noticed here that on the list was hypertension, which is definitely chronic. Is there any relationship to the observation reimbursement the whole situation, and the fact that some of these conditions were not allowed to have readmissions? Again, I don't think that CMS realizes that congestive heart failure is not going to necessarily go away. It's going to repeat, but is there any relationship between that and the fact that hospitals are not going to be reimbursed for certain readmissions?
I think that the fact that hospitals aren't going to be reimbursed for readmissions is simply a cost-cutting measure for Medicare. I don't think it
Okay.
has any relation to what's best for the patient or the particular ailment that they present with.
Okay, thank you.
It's simple demographics. I keep going back to this point, but it's an important point. The baby boomer generation is now enrolling day by day in Medicare, and with 10,000 new Medicare beneficiaries a day, it's very hard for the government to figure out how they're going to pay for this care when the Medicare program was already in financial trouble. Going all the way back to the 60s and the 70s when Medicare was new, the government paid what they called the lower of costs or charges, and hospitals submitted cost reports. and they paid the lower of the charges or the costs. When they introduced DRGs, they went to case rates, and any relationship to cost and charges began to disappear. One of the problems with hospital charges is this cost shifting that has gone on. Neither of the federal programs, Medicaid or Medicare, pay the cost of care. So hospitals made up the difference by charging an incremental amount more of private insurance and private pay patients. And so those bills are a hidden form of a secondary tax on the public to support those programs. There are times when you wonder if the whole thing isn't going to implode like a house of cards. And in fact, there are many pieces that would suggest that could happen in the Affordable Care Act. At some point, you have to be able to pay for the cost of care. The employees don't work for free. The suppliers don't provide supplies for free. Construction companies don't come here and build for free, and so on and so forth. And so when you begin to curtail the hospital's ability to shift that cost, hospitals begin to lose money. Now, a lot of discussion has occurred around St. Rose in the last year and our relationship potentially with them. One of the things that made it impossible for us was their payer mix. There aren't enough patients that are not sponsored by the federal programs to shift the costs to an inadequate amount to fund, to subsidize the federal patients at St. Rose. 80% of St. Rose's payer mix is Medicaid and Medicare. Only 7% was private insurance and PPO. So they didn't have a base to shift those costs to. With the Affordable Care Act being promulgated in pieces, the ability to cost shift for most hospitals is going to begin to disappear. I believe the federal government thinks it's a good thing if there are less hospitals instead of more, because it will cost them less if people don't have access. It's really that basic. These are big problems for consumers, for patients that need care. And I don't see hopeful signs of constructively dealing with this coming from the federal government. They have an overwhelming need to reduce expenditures, and that was seen in the process with sequestration and its expenditures across the board, not just for healthcare, it was for everything. But I think we have a situation where we've overpromised what can be delivered and we can't pay for it. And it means making really hard decisions around what's going to be covered and what isn't going to be covered. And we've had Governor Kitzhaber here before. He's currently the governor in Oregon. He's an emergency room physician. And what he had recommended many years ago, and I still think was a very good idea, was the idea of means testing for Medicare. That not everybody should get full Medicare free ride. That there are people that do have the financial means to pay a portion of the cost of their care. And to me, that was a very sensible way to begin to approach this problem. Instead, I think we're going to see some indiscriminate rationing of care. And already this has come out of sequestration. There has been a lot of discussion in the media about one of the results of sequestration, which was to reduce the payments to clinics and physician offices for very expensive oncology drugs that are used in chemotherapy. And clinics now beginning to turn patients away and saying, you know, we can't afford to give this to you for free or at the price that Medicare is paying for this, and therefore we can't see you anymore. And physician offices can't subsidize those expensive chemotherapeutic agents. Some of them are, $10,000 a month and beyond. I mean, it can become very expensive. And because they can't subsidize it out of their own office, they're sending the patients away. I think access problems and problems like that have arisen out of sequestration are going to become more common. And I can't imagine a more tragic or difficult problem for a cancer patient than that. And I think these things will rise to the surface and get the attention that they need, but we still have a problem with having overpromised what we can provide as a society. So, the money's not there to do everything. And this implicit rationing as opposed to explicit rationing is very difficult.
And it doesn't work very well. And that's one of the problems with it's basically imposing the sequestration style management upon the healthcare system, in which you just squeeze from the top and you don't manage each individual program and illness and treatment as is optimal for maximizing the benefit of the healthcare dollars. One of the best work that I saw from Dr. Kitzhaber, Governor Kitzhaber, was that he actually impaneled a group of healthcare experts to look at the relative merits of a lot of different treatments. And then for the treatments which were sponsored by this state of Oregon, they would rank those treatments. What are the most valuable? Where do you get the most healthcare benefit for an individual dollar spent? And they would go down that list until they ran out of money. So they would decide what they were going to spend money on and what they were not. That was a very explicit way of coming to these decisions. I'm sure there was a lot of political fighting when these things were announced, but it did work for them. Yeah. We need to have the same kind of decision making as we move forward in this country to help us decide what is the best way we can spend a very large but limited amount of healthcare dollars.
When he did that as governor, this was in his first round as governor of Oregon, they held public hearings. And the public was allowed to come and participate and say their piece. And they did weigh the relative value of spending a tremendous amount of money in the last 6 months of someone's life versus the astronomical amount of money it sometimes costs to preserve the life of a neonate that was born underweight. And there were very explicit discussions about the values of those things. And I know those are tough discussions. And I know that gets people very heated and worked up, but I think they're necessary discussions. Difficult, but necessary.
Yeah. This country has a lot of work to do.
Yeah, there's a tremendous amount of work to do. What I worry about is that a lot of people are going to get hurt on the way to us getting there. And at the bottom of the pile in all of this are the patients.
Right.
And decisions get made in Washington, D.C. without a full understanding of what it looks like and plays out at the local level, and that's here. We're ground zero for that, and we see it every day, but I'm not sure that it's well understood. And I see that as a problem. It becomes very indiscriminate rationing, and people get hurt.
I think we have a lot of work to do to try to educate our representatives in Congress as far as what the issues are and how we see they can be best addressed. But a lot of work to be done.
Yeah.
Thank you. Thank you, Chris. We'll keep our eye on observation.
Yeah.
We have consideration of the minutes from March 13, 18, and April 4. If I could have a motion. So moved, Mr. President.
Second.
We have a second from Director Danielson. All in favor?
Aye.
Aye. Any opposed? Motion passes. Do we have any oral communications? Catherine, did you get any speaker cards? No. Okay. Then, in that case, we'll move on to Dr. Romano.
Thank you, Dr. Nicholson. I'd like to present the medical staff proposed credentials action items from the month of March. We have 6 new appointments. Amir Jamali to orthopedics for provisional active. Robert Mandenberg, emergency medicine, provisional active. Dale Tyler, otolaryngology, provisional active. Patrick Duffy, oral and maxillofacial surgery, to provisional courtesy. Joselle Whalen, physician assistant, to provisional active. And Lotfi Hussein Bey, neurointerventionalist, for provisional active. The reappointments are Dr. Abraham Ahmadi, family medicine active. Uni Barish, internal medicine active. Victor Maseda, family medicine active. Nita Patel, OBGYN active. Robert Pipkin, Department of Surgery and Administration. Aruna Reddy, family medicine ambulatory. Sharon Singh, neurology active. Meena Tandon, pathology courtesy. Milford Zaslow, anesthesiology active staff, and Joseph Zamudo, family medicine active staff. We are recommending 3 transfers in staff category. Dr. Tamara Cheney, Suzanne Shu, and Joseph Zamudo, all family medicine specialists, moving from active to ambulatory. There is 1 transfer in staff category. Dr. Dushyant Oza from pediatrics is retiring, so we're going to move him to the retired staff. For completion of proctorship, we have 1 physician, Xingmin John Liu. We're discontinuing proctorship and advancing to the active staff. He's in pediatrics. And number C3, we would like to recommend extending proctorship as well as the provisional category for Lily No in pediatrics and Vivian Tsai. Dr. No is in provisional ambulatory. Dr. Tsai is provisional active. Finally, we have 3 resignations. Arash Forutani, internal medicine. Ryan O'Connor, emergency medicine. And Angela Wong, family medicine.
Great. Thank you very much, Dr. Romano. Could I have a motion for approval of the credentialing action items?
So moved, Mr. President.
Thank you.
Second.
We have a second from Director Danielson. All in favor?
Aye.
Any opposed? Motion passes. Jeannie,
Hello.
Service League report.
Thank you. This month we held our quarterly Hours Pin Awards lunch for the volunteers that had reached their next milestone of pins. These hour pins that we wear, they start at 200 hours, and they earn at 200 hours, and then the next one's 500 hours, and then 500 hours after that. And if you think that the average hospital volunteer stays between 1 and 3 years, working the minimum required hours that we have of twice a month, it would take 2 years to get their first 200-hour pin. Mm-hmm. Well, we had 18 that came, and several had reached their 200-hour pin. And we had several at 500 and 1,000 and 2,500. And our top one was 14,000 hours.
Wow.
By Joyce Wallace, who's one of our gift shop managers, been here 27 years. And she considers herself one of the young ones. So, but 14,000 hours is definitely something we all strive for. We don't work for the pins. Well, the majority of us don't, but in general. But what they do is they tell people that we enjoy what we do. So when they look and they see your hours pin, they know that you like what you do, and that's why we do that. Now, at the end of the month, back by popular demand, we have our $5 jewelry sale. Masquerade is coming. They're a wonderful fundraiser for us. In last year, we have it for 3 days in the spring and 3 days in the fall. In those 6 days last year, we earned $33,440 for 6 days of work. That's thanks to everybody here and in the community. The interest for this continues to generate and grow, and everybody's so excited. Their motto is experience the frenzy. And that's kind of what happens when you get a bunch of people in a room going, what? This is all just $5? We always say plus tax, plus tax. But it's really a fun thing to do, and it works well for us here, and in turn means more that we can give to the hospital at the end of the year. So,
What are the dates?
oh, that's a secret. Monday and Tuesday, April 29 and 30.
Good.
We open at 7, close at 6, and then on Wednesday, May 1st, from 7 to 5 a.m., and it's going to be in Anderson C
So it's
here.
going to be here rather than in the
Yeah,
lobby?
exactly,
Okay.
yes. We tried that a couple
Right.
times, it's, no, it's not
yeah.
going to work. And it's much nicer over, oh yeah, that's all we need is more noise and commotion. So it's here, more parking and everything, it works out great. So I have flyers if any of you want to take any back to your office. I'm not advertising, I'm just informing. It's part
Doors
of my
open at
report.
what?
7.
7 o'clock, okay.
Yeah, 7 o'clock?
All
Yep.
right.
So thank you.
Thank you very much, Jeannie.
Jeannie, is the area here going to be enlarged?
I believe we just still have the one room.
The one room? Okay. We'll just all cram in there together.
Hey, more the merrier.
It calls for multiple trips.
Exactly, and every day there's new stuff.
I know.
And you know, if you see it one day, you can't count on it being there the next.
Now, if you,
so-
if you see it, you like it, you buy it.
That's right. Visa, MasterCard, cash.
And we need to also make sure that people know that sometimes because of the spacing, they put things up high. Because remember the little hats?
Oh,
They were
yes.
up high, and I almost missed them last time. But I found them.
That's right, you become a smart shopper with us. Thank you.
Great, thank you very much, Jeannie. Dr. Romano, medical staff report.
Yeah, well, let me just say to Jeannie, I do have my cell phone holster, which comes from the $5 sale.
You know, it's not just jewelry, it's things
It's
for...
lots of
Practical
good
as
stuff.
well. So the medical staff report is in your agenda. The first page shows a little vignette on the 6 members that were approved this evening. After that, you'll see the status of the applications, including 5 pre-applications and 8 applications. 4 of those applicants were acted on tonight. And the last page there shows the total members of the medical staff, which is at 535. 399 of those are active and provisional active. So hovering right there. I suspect it'll be interesting the next couple of months to see with the startup of Epic, how many people may retire and how many people may change their staff category. Status would be interesting. Thank you.
Thank you very much, Dr. Romano. Nancy, hospital calendar.
Okay, we'll start with
The video.
Past health promotions and outreach events. On March 13th, as part of the evening lecture series, Macaria Meyer, registered dietitian, presented Eating Clean. She provided information on how to create healthy meals using unrefined whole foods. 18 people attended. On March 14th, Dr. Gabriel Herskew, vascular and endovascular surgeon, presented to the Union City Lions Club and Fun Sunset Rotary Club. Dr. Herskew presented on vein rejuvenation and minimally invasive surgery. 60 people attended. On March 15th, Christy Caracappa, Health Insurance Information Service Coordinator, presented on health insurance options to members of ProNet. ProNet provides support and education for professionals in career transition. 50 people attended. Also on March 15th, in celebration of St. Patrick's Day, the City of Fremont Recreation Department hosted an interactive, life-size game and maze for children to have fun and learn about leprechauns. Washington Township Medical Foundation was a sponsor of this event. Washington Township Medical Foundation pediatricians were on hand and provided information on children's health topics. The City of Fremont estimates that 400 people attended. On March 16th, the Washington Center for Wound Healing and Hyperbaric Medicine held a follow-up free foot screening to accommodate those who were unable to attend the screening held in February. Dr. Prasad Kilaru, plastic surgeon, provided personalized lessons on how to care for one's feet. 16 people were screened. On March 16th, the Fremont Chamber of Commerce hosted Bowling for Scholars, a bowl-a-thon for the Dollars for Scholars program. Washington Hospital's Health Spares team participated in the friendly tournament to help raise money for scholarships that will be awarded to local high school students pursuing a post-secondary education. On March 20th, Lucy Hernandez, Operations Coordinator, provided information on Washington Hospital along with bone density screenings for osteoporosis at Alma Via Assisted Living Health Screening Day. 24 people were screened and 35 people visited Washington Hospital's booth. On March 23rd, Washington Hospital held the annual Stroke Awareness Screening Day. Each participant underwent a carotid artery screening, an EKG to screen for atrial fibrillation, as well as cholesterol, blood pressure, and glucose screenings. Participants met with a physician to discuss the results and risk factors for stroke. Dr. Ash Jane, cardiologist, provided the physician interpretations, and Doug Van Houten, RN, coordinated the event and provided patient education. Fremont Bank sponsored this event. 100 people were screened. No carotid occlusions were detected. However, 39 of those screened had abnormal cholesterol levels or blood glucose levels. 5 were found to have abnormal heart rhythms, and 8 participants were found to be at high risk for stroke. Also on March 23rd, Washington Hospital participated in the Take Control of Your Diabetes Conference, held at the Santa Clara Convention Center. Diana Jaycox, RN, staffed a vendor booth and provided information on diabetes prevention and management. The TCOYD conference estimates that 1,500 people attended this event. On March 29th, Washington Hospital hosted its annual Doctor's Day Luncheon. It was held in recognition of our physician staff and their dedication to providing high-quality medical care to our community. Approximately 120 doctors attended. On April 2nd, as part of the Stroke Education Series, Dr. Ash Jane, cardiologist, and Doug Van Houten, RN, presented Living with Stroke and Future Diagnosis and Management. 15 people attended. Also on April 2nd, Doctors Swetha Kausik and Amy Tunn, pediatricians with Washington Township Medical Foundation, presented to the Fremont Newark Union City Fun Moms Group on age-appropriate milestones for children. 20 parents attended. On April 4th, as part of the Diabetes Matters program, Dr. Prasad Kata, endocrinologist, presented the ABCs of diabetes. 42 people attended. Upcoming health promotions and community outreach events. On April 10th, from 7 p.m. to 8 p.m., as part of the Washington Women's Center Evening Lecture Series, Dr. Neetam Verma, sleep medicine specialist with Washington Township Medical Foundation, will present on insomnia. On April 12th, from 2 p.m. to 4 p.m., Dr. Alexander Saw, orthopedic surgeon, and Dr. John Dearborn, orthopedic surgeon, will present Don't Let Achy Knees Slow You Down, Osteoarthritis and Knee Replacement. On April 17th, from 8 a.m. to 10 a.m., Dr. Swetha Kausik, pediatrician with Washington Township Medical Foundation, will present at the Hopkins Junior High School Career Day. On April 20th, from 11 a.m. to 3 p.m., Washington Hospital's Green Team, the City of Fremont, and other local Tri-City organizations will present the Let's Go Green Together event. This free Earth Day Education Expo will raise environmental awareness and share eco-friendly ideas with people in our district. Attendees are encouraged to learn about recycling and how to save energy. On April 23rd, from 10 a.m. to noon, Christy Caracappa, Health Insurance Information Service Coordinator, will present on health insurance options. On April 24th, from 2 p.m. to 3 p.m., Christy Caracappa, Health Insurance Information Service Coordinator, will also present to the Better Breathers Club on Medicare coverage. On April 26th, Washington Hospital will host its annual Volunteer Appreciation Luncheon at the Fremont Marriott Hotel. This event will honor the Washington Hospital volunteers during National Volunteer Appreciation Week. On May 2nd, from 7 p.m. to 8 p.m., as part of the Diabetes Matters program, Anna Mazzei, registered dietitian, will present Diabetes Meal Planning, Peaks and Pitfalls of a Vegetarian Diet. On May 7th, from 6 p.m. to 8 p.m., as part of the Stroke Education Series, Dr. Ashchain, cardiologist, and Doug Van Houten, RN, will present Introduction Stroke and Risk Factors for Stroke. The Washington Hospital Healthcare Foundation Report. On March 27th, the John F. Kennedy High School Cancer Awareness Committee donated an iPad to the Sandy Amos RN Infusion Center. The iPad is available to infusion patients during treatments. The Cancer Awareness Committee is made up of students who have been affected by cancer. On April 4th, as part of the Half Pint Library Book Giveaway, Half Price Books of Fremont donated over 200 children's books to Washington Hospital Healthcare Foundation for kids waiting in the emergency room. The Foundation Golf Tournament Committee is working hard to ensure a great day of play for golfers at the Washington Hospital Healthcare Foundation Golf Tournament, being held at the Black Hawk Country Club in Danville on June 24, 2013. The tournament, named in memory of longtime Fremont businessman Jean Angelo Pisano, raises money to support hospice care and surgical services. To sponsor the tournament or to reserve your foursome, please call Washington Hospital Healthcare Foundation at 510-791-3428. The Washington Township Healthcare District Board of Directors Report. On March 20th, board member Patricia Danielson attended the Union City Chamber of Commerce Spirit Awards luncheon. At the luncheon, the Union City Chamber of Commerce Spirit Awards were presented to individuals who have made an impact in their community and the lives of others. Washington Hospital Healthcare Foundation Executive Director Angus Cochran was awarded the Business Spirit Award for 2013. On March 22nd, board members Patricia Danielson and Dr. Jacob Epen attended the Indo-American Community Federation's 12th Annual Unity Dinner. On March 28th, board members Patricia Danielson and Dr. Jacob Epen attended the Fremont Chamber of Commerce State of the City Address given by Mayor Bill Harrison. On March 28th, board member Patricia Danielson and Dr. Bernard Stewart attended the annual dinner meeting of the Alameda County Special Districts Association. Washington Hospital Employee Association, WIA. On April 1st, WIA sponsored a blood drive in conjunction with the American Red Cross. 26 people registered and a total of 18 pints of blood were collected as a result of the event. All applications for Washington Hospital Employees Association Don Pickenpaugh Memorial Scholarship were turned in on April 5th. This $2,000 scholarship is available for dependents of Washington Hospital who are enrolled as a full-time senior in a California high school or are pursuing a degree as a half-time or more student at an accredited college, university, or vocational school. The winner of this scholarship will be announced in May. Washington on Wheels, WOW, Mobile Health Clinic. During the month of March, Washington on Wheels Mobile Health Clinic, WOW, continued to serve community members at the Fremont Family Resource Center, the Silman Activity Center in Newark, the New Haven Adult School, and the Ruggieri Senior Center, both located in Union City. WOW also provided healthcare services to students and families at Grimmer and Breyer Elementary School and Robertson High School, all located in Fremont. WOW provided 64 occupational health physicals to Tesla employees. In addition, WOW provided wellness exams for members of the Operating Engineers Union through Health Dynamics. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was March's most viewed webpage with 15,307 views. Other active sections include InHealth, Channel 78. During the month of March, Washington Hospital's cable channel, 78 InHealth, aired new programming, including varicose veins and chronic venous disease, keeping your heart on the right beat, atrial fibrillation, Diabetes Matters, Diabetes Resources, Where to Go for Help, and the February Board of Directors meeting. InHealth also taped several new programs, including Diabetes Matters, Diabetes Update 2013, What's New, the March Board meeting, and the Active Shooter Awareness Training. For more information on any of the programs mentioned, visit WHHS.com or call 1-800-963-7070.
In addition to those activities, I wanted to mention that about 1 o'clock in the morning on Tuesday this week, we completed a hardware, firmware, and software upgrade of our Nortel phone system. Now, last time we tried to do this years ago, we went through weeks of downtime. This all occurred in the wee hours of the morning, flawlessly. The preparation for it was outstanding. There were key members of the IS staff, Information Services staff, that were responsible for such a successful phone switch upgrade. I can only wish that we had had them years ago to help us. Mary Ann Kerr is the Information Services telephone lead, and John Lee is a Senior Director of Information Services Infrastructure and Technology, Vox Network Solutions Maintenance and Support vendors. And they did, Vox Network Solutions was our maintenance and support vendor that helped them do this. And they were also very, very helpful. So we had some of our executive team here at 1 o'clock in the morning, and a lot of us at home wondering how this was going to go. And mercifully, it was a very clean process, very well organized, very well executed, and just momentary lapses in phone service while this occurred. The other thing I wanted to spend a little time talking about is something that happened here today, and that was the active shooter drill. Perhaps a sign of our times that we thought that we needed to do this. We did retain the services of a consultant by the name of Kerry Harris. He did come to the hospital and do training with our employees. His session is about a little bit over an hour long, and depending on how many questions there are, and there always are a lot, longer. This is a hard thing for people to adjust to, because what's necessary in an active shooter situation is the antithesis of everything we've been taught about how we prepare for disasters in a hospital. And shelter in place is something that's been drummed into all of us over the years. In this particular kind of incident, you have to wrap your mind around the concept of run. It's a fight or flight kind of decision. And one of the things you come to understand is that this can happen anywhere. It could happen here, or it could happen in a church, it could happen in a stadium, at a college, and at a grammar school. There are any number of places where this can happen. So any of the training that we've provided for our employees, I feel as though, I hope to God we never have to use it here. But this could happen elsewhere in their lives, and I think it's an important kind of training for people to go through. We did this drill with the Fremont Police Department. And part of the drill is that a member of the police department is dressed as an active shooter. And we had to make a decision yesterday about whether or not we were going to allow them to fire blanks in the building. So we went over to the central utility building, to the conference room, and had them fire it there so that we could hear what it sounded like. And we made the decision that that could happen here. It's a loud popping noise. It's not as loud as a real gun being discharged. But it is a formidable thing to see somebody come down the hall and go into one of our departments and do that and move from department to department, firing blanks. It's also a formidable thing to see the Fremont Police Department come down the hall with their guns drawn. It's upsetting for some people. We, I think, did an especially good job of blanketing Washington West yesterday with flyers, making sure people understood that this is a drill, this is not real. The big concern is that a patient, a visitor, or an employee would think that it was real, and that could be incredibly traumatic. So we had an abundance of people here in the building. The executive team divided up the building and each took a zone and was responsible for walking through an hour before the drill, talking to everybody to make sure they understood what would happen here. A number of the members of the public who were here while this was going on walked up to staff and basically gave them the message they were sorry that we had to do this, but they were sure glad that we were doing it. So we learned a lot of things in the process of this drill. And I think it will help the Fremont Police Department and the hospital work very closely together if something like this should ever come up on our premises. That may not be the only drill like this that we do going forward. In talking with our consultant, Carrie Harris, one of the things I learned was, and I was surprised to learn this, that there are more active shooter incidents in hospitals than in other places. And that was disturbing. There was a moment in time before this drill occurred today where I was wondering, do we really need to do this here, or are we just going to upset people terribly? And then the news from Texas came, and I decided, yeah, we have to do this. And I don't know if the media is reporting this more frequently because Congress is considering gun control measures at this point in time, and the parents from Sandy Hook have been so active, or whether it's just beginning to happen more and more frequently. I don't know. But I felt that we had to do this, and so we did. We had observers from several Kaiser hospitals and also from Eden here to see how this went. And I think the overall feeling was that it went extremely well. People were well prepared. They had received the training. There is a 5-minute video that our consultant who prepared us for this showed to our employees, and then that was followed by a very extensive discussion. I wanted you to see that 5-minute video now.
It may feel like just another day at the office, but occasionally, life feels more like an action movie than reality. The authorities are working hard to protect you and to protect our public spaces. But sometimes bad people do bad things. Their motivations are different. The warning signs may vary, but the devastating effects are the same. And unfortunately, you need to be prepared for the worst. If you were ever to find yourself in the middle of an active shooter event, your survival may depend on whether or not you have a plan. The plan doesn't have to be complicated. There are 3 things you could do that make a difference: run, hide, fight. First and foremost, if you can get out, do. Always try and escape or evacuate, even when others insist on staying. Encourage others to leave with you, but don't let them slow you down with indecision. Remember what's important, you, not your stuff. Leave your belongings behind and try to find a way to get out safely. Trying to get yourself out of harm's way needs to be your #1 priority. Once you are out of the line of fire, try to prevent others from walking into the danger zone and call 911. If you can't get out safely, you need to find a place to hide. Act quickly and quietly. Try to secure your hiding place the best you can. Turn out lights, and if possible, remember to lock doors. Silence your ringer and vibration mode on your cell phone. And if you can't find a safe room or closet, try to conceal yourself behind large objects that may protect you. Do your best to remain quiet and calm. As a last resort, if your life is at risk, whether you are alone or working together as a group, fight. Act with aggression. Improvise weapons. Disarm him. And commit to taking the shooter down, no matter what. Try to be aware of your environment. Always have an exit plan. Know that in an incident like this, victims are generally chosen randomly. The event is unpredictable and may evolve quickly. The first responders on the scene are not there to evacuate or tend to the injured. They are well trained and are there to stop the shooter. Your actions can make a difference for your safety and survival. Be aware and be prepared. And if you find yourself facing an active shooter, there are 3 key things you need to remember to survive. Run, hide, fight.
I think one of the most important points to make is that what we've been taught to do to survive an earthquake or other kinds of disasters that we typically have drilled for in a hospital setting has been to shelter in place, and that is the worst thing you could do if other options are available to you in this kind of a situation. And that is how the teachers at Sandy Hook were trained. And so they gathered their children in a room, and they became easy targets for somebody who is interested in killing a lot of people. And part of the psychology that's of a shooter that's been explained to us in these sessions is that they're looking to shoot as many people as they can, the more the better. And so by gathering everybody together in one place, you're helping them accomplish their objective. We have a lot of discussions ahead of us in terms of what do we do if this happens in a patient care area where there are helpless patients who can't move. And these are discussions that we'll be having with our consultant and the police department in the ensuing months. I would like to thank Gus Arroyo, our head of security, for all the hard work that he did to get this done. It wasn't an easy thing to do. It wasn't a pleasant thing to do, but it was a very necessary thing to do. And we'll go on with the planning around this. It's a grim subject. The last thing I'd like to talk about is a pleasant subject, and that would be our Employee of the Month. And this is Eric Sampson. He's a dependable, familiar voice for our surgeons, physicians' office staff, the perioperative nursing staff, and even our sales reps that come to Washington Hospital. He's the scheduling secretary in the operating room. And in addition to scheduling, he does a lot of other things. He schedules for the endoscopy department, and he reviews charges and requests charge codes, ensures that all journaling is correct in our various systems, and he runs reports as needed for a variety of our internal needs. And he does all of this with professional quality and good humor. He exemplifies the term customer service, and he's a team player. His coworkers say that he's enjoyable to work with and that he's always there to lean on if the department needs help. He has a very positive attitude, and he's known for a great sense of humor, making going to work easy and fun. He's also a big San Francisco 49ers fan, and he enjoys golf and working out at the gym. He's known best for being a foodie. He tweets on Yelp to other food aficionados about the best places to eat in the Bay Area, so he would be a good person to consult if you're looking for a restaurant. He's been invited to special food events due to his timely and insightful comments on the internet. And he's been spotted hiking Mission Peak and eating at the House of Prime Rib in San Francisco. He's our April Employee of the Month.
Thank you, Nancy. Anything else? We'll move on to our quality report. Stephanie, we're going to talk about the intensivist program. I think that's a great thing to talk about.
For those of you that have visited the critical care lately, for the last 3 years, you would notice that we have doctors around the clock in the intensive care. So why an intensive care program? It's the right care right now, and it's for the critically ill and injured patient. Remember the days when you needed a physician and your patient was deteriorating in the ICU? You had to wait 30 minutes, 45 minutes for maybe that physician to come in. Those days are gone. With the advent of intensivist programs, the care is delivered right there, right now. So who are these intensivists? They are physicians that provide direct care to the hospital intensive care unit. They work in collaboration with the physician, the attending physician, as well as the multidisciplinary team. And by the multidisciplinary team, I mean the nurses, the pharmacists, respiratory therapists. They all work as a cohesive group, making it patient-centered care. Let's talk a little bit about the training, because these are highly specialized physicians. They are usually board certified in specialties such as surgery, internal medicine, anesthesiology, or pediatrics. And then they go beyond that for an additional 2 to 3 years in a fellowship or certification in critical care. So they are highly trained physicians. So let's talk why we should have an intensivist program. It's the patient-first ethics. It is the right thing to do for the patient. It provides 24/7 coverage. It's the highest standard of care. It's considered the gold standard of care by the Critical Care Society. It is focused on patient safety, making sure that everything is done for the patient with the best evidence care out there. It improves patient outcomes, and the literature has shown that over and over again. And it optimizes efficiency in providing appropriate care. It allows for the daily rounding with the multidisciplinary team and the attending to discuss what's the goal for that patient for that particular day. So let's talk a little bit about the benefits associated with intensivist approach. Increased survival, improved morbidity and mortality, fewer treatments and procedure complications, less adverse events, improved patient and staff satisfaction. It reduces the length of stay. The literature has shown that where there are intensivists, the length of stay goes from about 9 days to 6 days. So it decreases the length of stay by at least 3 days. It decreases the time the patient, for those patients that have a breathing tube, a mechanical breathing tube, their care helps drive that the patients are spending less time on the ventilator, which is a positive. And again, it talks about being cohesive, being collaborative, doing what's best for the patient. Let's talk about our intensivist program here at Washington Hospital. Dr. Carmen Aquilili is our medical director for the intensivist program. She's a very dynamic, energized physician. This is her passion. We have 1 physician per 12-hour shift. We have 5 full-time physicians, 5 part-time, and they are all board certified. And again, we use the multidisciplinary team approach, rounding with the team. Anybody that comes in contact with that patient, that's providing care for that patient, they have become one unit. We started with a 24/7 coverage since 2009, and they work in conjunction with the primary care doctor and the attending physician for the coordination of care. What are our objectives in terms of an intensivist programs? We wanted to develop an infrastructure that promotes patient safety and quality care. We wanted to identify and improve the condition of our patients. We wanted the right care right now for our patients. We wanted to provide the best treatment out there. We wanted to do appropriate, reliable, and timely care to our high-risk and critical care patients. They are the most vulnerable patients that are in the ICU. They're the ones oftentimes that have the multi-organ system failure. We wanted a team that is patient-centered and family-centered in terms of providing care for that patient, using the best tools, the best devices, and the best care out there in terms of providing care for our patients. And again, we wanted to make the patient and the family the center of our care. The ICU over time has taken on many projects. So tonight I'm going to discuss just a few of the projects that they have taken on. The delirium project you will hear a little bit about, blood transfusion and what they have done with that, nutritional assessment in ICU. You heard from Kim tonight about the importance of having a nutritional assessment. And you're going to hear a little bit about palliative care. Those are some of the initiatives they have taken on. And for those of you that are not familiar with palliative care, this is a specialized medical care for people with serious illnesses. It's focused on the patients, giving relief to the patients, the symptoms and pain and stress of serious illnesses. It doesn't matter what the diagnosis is. And the goal is to improve the quality of life for both the patient and the family. And we have a family assistant program. So let's talk a little bit about delirium. Because delirium is also known as a severe state of confusion. And most people have not associated the confusion with delirium. And oftentimes, if you're in the ICU or critical care for any length of time, you will discover delirium. It is also known as ICU psychosis. It's known as sundowning, and it's known as encephalopathy. And they're all about the patient becomes confused. At times, the next morning, they do better. Like, for instance, during the day, they're fine. At night, they become confused, and that's known as sundowning. So again, they all have to do with confusion. And over time, it disappears, and sometimes it takes a little while for that patient to recover. So what have we done about it? We wanted to increase the awareness of delirium with the healthcare team. So Dr. Aquilili and her group, and she has a dedicated group that's focusing on delirium in the ICU. And the goal was to prevent and treat ICU delirium earlier. The sooner you get those patients identified, the sooner you start intervention, the better the outcome for those patients. So as of now, we screen all patients in the ICU are assessed for delirium. It's a routine part of our clinical assessment. And it does, at the end of the day, improve patient care. Nutritional assessment in the ICU. All our patients are assessed for malnutrition risk. There's early intervention. The dietitian is part of that multidisciplinary team, multidisciplinary approach. And the whole goal behind it is to promote healing and recovery. And again, this goes hand in hand with early mobility. You get them out of bed, you identify their needs, and oftentimes these patients, when they come in, they're so malnutrition. So the earlier we know that they are malnutrition, the earlier we can get them starting on nutrition. The Family Assistance Program is one of Dr. Aquilili's passion. We have developed an ICU orientation brochure that tells a little bit about the ICU, exactly what goes on there, the visiting hours, some of the services provided. They also do a questionnaire with the patient's family, and they want to know about that patient. Tell me a little bit about him. Who is he? What is his passion? What does he do? What does he like? What is his... So this is getting to know the patient so they can begin to focus the care on that patient. And that is the work that's evolving over time. And they're beginning to look at family communication strategies. They're talking to the family to tell us, how are we doing? So that we can learn from the patients and the family. And it has been very positive. And that too is evolving over time. Let's look a little bit at our results. The ventilator-associated pneumonia. These are patients that have a mechanical breathing tube in them, and they're prone to infections, they're prone to pneumonia. And this has been one of the IHI initiatives from day one. And we have gone over 1,100 days without any incidents of ventilator-associated pneumonia. That is awesome in terms of looking at the team, that multidisciplinary approach with the physicians, the respiratory therapists, the nurses, the pharmacists. There's a bundle that we follow for this patient population, and the result shows. The ICU mortality, this is the last data that came out of CHART. CHART used to be one of the Bay Area initiative that's no longer active. And again, when you look at our mortality versus what the mortality was for the Bay Area that participated in the CHART initiative, our mortality was less. So that's showing that we were trending in the right position. Looking at MRSA, and this is the bloodstream infection, and again, we're looking at the time for calendar year 2012. and we had none. Looking at the days on the ventilator in critical care, there's a lot of work done by the intensivists and the respiratory therapists in the unit. And we have seen our days come way down. We have seen that the patients are being off the ventilator a lot sooner than they were in the past. And that too leads to outcomes, to improve outcomes. So these are just a small sampling of what's going on in the critical care as it relates to our intensivist program. These are some of the continued objectives that are taking place. We talked a little bit about mobility. We're trying to get all the patients out of bed, get them moving, get them eating. So the sooner we do that, the sooner we can get them out of the ICU, the sooner they can get out of the hospital and back home to where they belong. Infection control practices. We were looking to make sure that we have hospital-acquired infections are down to a minimum. We do what's best practice. We have, as part of this team, we have our infectious disease physician, Dr. Diane Martin, that makes rounds in the ICU with the multidisciplinary team. Again, we're going for that multidisciplinary approach. Communication. The goal is to communicate with the physician, with the patient, so everybody's on the same page, talking the same language to the patient and the families in terms of what's going on. And we're looking at one of the deficits that was noticed in terms of talking to the families. When the patients are transferred from the ICU, there is not always that coordination that we would like, so there's work being done as it relates to transferring those patients out of the ICU to a med-surg unit. So that is being worked on with the critical care team and the intensivists right now. And that's about it in terms of a snapshot of some of the things that are going on in critical care as it relates to the intensivist program.
Great, thank you very much, Stephanie. Any questions? I just want to make a comment, and I can't be more impressed, and as a physician, more grateful for the amazing work that has been done in developing our intensivist program. Dr. Akawili, Dr. Azizarad, Dr. Kapoor, Dr. Liu, have just done amazing work. It is such a good thing, and your presentation was good, but it really does not truly reveal the good work that's been done. I mean, that I think patients and their families will see when they get treated in the ICU. The absolute top quality care that they get, the fact that somebody is there 24/7 makes such a tremendous difference. And the incredible skill and talent that these people have. I left out Dr. Sweeney. Don't forget Dr. Sweeney.
Yes, Dr. Sweeney, of course.
He was working hard last night, and I'm grateful for that. So they do wonderful work. I think it's just an amazing program. So more power to them.
More power to them.
Yeah.
Absolutely.
Thank you. I think we have our finance report.
Okay, tonight we will be looking at the results of operations and finances, the financials for February 2013. Take a quick run through our operating indicators. Our average daily census for February was 19.6, below the budget at 185.8. We had 942 admissions during the month, about 1,061 less than we had expected. And likewise, our patient days were below budget by 551 at 5,201. We had 277 outpatient observation days in February, 24 above the budget. And our average length of stay for the month was actually higher than we've seen it for a while at 4.35, but still below, slightly below the budget of 5.42. Looking at utilization, the case mix index for the month remained high as we've seen it all year at 1.539. We had 153 deliveries for the month. We'd expected 161. Surgical cases were pretty close to budget at 348, just 3 below the budget. That includes our joint replacement cases that were 19 above budget at 116. We did 14 neurosurgical cases in February. We'd expected to do 21. Our cardiac surgical cases came in right on budget at 11. And our PTCA procedures in the cath lab were 7 below budget at 44. Outpatient visits for the month came in at 7,581. We'd expected 8,788 for February. However, the emergency room continued its pace of activity with 4,420 visits. We'd expected 44,104 in February, so they were significantly above what we expected. Looking at productivity, February we saw 1,354.6 productive FTEs, 156.6 non-productive full-time equivalents for the month, giving us total FTEs 5.4 below the budget at 1,511.2. Our full-time equivalents per adjusted occupied bed, which is our productivity measure, came in above the budget at 6.20. We'd expected 5.75 for February. Moving into the financials, and as we always do, we'll first look at our representation of our Governmental Accounting Standards Board presentation. Total patient revenue for February came in almost $1.6 million below the budget at $174,644,000. Our contractuals for the month came in higher than budget at $77.2, and that was a result of an unfavorable payer mix compared to what we had been seeing. Did see more government, less PPO in February. So we ended up with net operating revenue for the February $2.648 million below the budget at $40,103,000. Operating expenses for the month came in a little more than $2.5 million below budget at $39,153,000. We saw that variance in the areas of benefits. We had lower health and welfare claims during the month. Our supplies were below budget with our lower census and activity numbers. Our purchase services and pro fees likewise were below budget. And our provision for bad debt and charity was below budget. We did see slightly lower bad debt applications during the month than we've been seeing. So we end February with an operating bottom line about $120,000 less than we expected in the budget at $945,000. Non-operating income for the month came in $740,000 above the budget at $2,022,000. So we ended the month of February with a total bottom line from a GASB perspective about $620,000 above the budget at $2,967,000. Quickly taking a look at our Financial Accounting Standards Board presentation, and this is our representation of how the financial markets look at us. The operating bottom line does not change at $945,000. We pull out our unrealized gain on our investments for the month and our income to support our general obligation bonds to end up with non-operating income from a FASB perspective about $144,000 lower than we expected in the budget at $464,000, and a total bottom line from a FASB perspective of $1,409,000. So are there any questions on February results?
Thank you very much, Chris. Okay. We'll go on to our operations report.
Catherine just reminded me that I intended to cover a topic in my earlier calendar report that I neglected to cover. And it's an important topic because there's been so much commentary in the press about our Center for Joint Replacement and our Institute for Joint Replacement program. And there have been a number of recent articles that appeared in the press. But I wanted to read a letter to the editor that was published, and it's from one of our patients. And it starts with the statement, "The story about doctors was a biased report." One of the things that makes a good reporter is non-biased reporting. I found the recent article on Doctors Dearborn and Saw very biased. Perhaps the paper should have contacted a couple of their patients before writing the article. For almost 3 years, I have been in a lot of pain. I have not been able to travel long distances and had complete change in my life because a doctor who claims to be a top orthopedic surgeon who botched the procedure of replacing my knees. Since Dr. Saw revised the replacements, my life is changing each day. Do I think a higher level of training, criteria, and care should be mandatory? You bet I do. I am in no way a wealthy person, and a lot of doctors are no longer taking Medicare because of funding cutbacks. My Medicare was taken by Dr. Saw with no problem. I'm only sorry I did not go to him the first time and saved myself a lot of pain and my insurance company a lot of money. Signed by a patient by the name of Phyllis Swallow from Hollister. And frankly, the letter perfectly describes the reason why we set up the Institute for Joint Restoration and Research. It is to change patients' lives for the better by offering specialized and experienced care by physicians who have decided to concentrate their entire medical practice in the field of joint replacement and who have made a commitment to constantly improve patient outcomes through research. I don't know what percentage of their practice is committed to reduce, but I know it's a significant feature. As you know, on March 23rd, the Argus ran an article regarding our new program, the Institute for Joint Restoration and Research. That was followed on March 27th with an opinion piece. Both the article and the opinion piece were misleading in many ways. What we would like the board and the community to know is that prior to the publication of the article, staff answered dozens of questions for this reporter. Because we were concerned that the reporter did not understand the new institute, we provided her with comprehensive 6-page detailed explanation of the purpose of this program, the history of the development of the institute, and the legal structure of the program. We have these available for you. We'd be happy to provide a copy to anyone from the public who might be interested in knowing the full story about the Institute for Joint Restoration and Research. The board and the public should know that as of the date of our letter, we had received only 3 patient complaints about the program, and these were complaints largely about the fact that these patients were placed on the 6th floor after surgery and that care was in some way substandard. While we certainly strive to have no complaints, 3 complaints is by any standard a modest number, given the number of patients who've had joint replacement procedures at the hospital. In our letter, we offered the reporter an opportunity to get testimonials from hundreds of patients who, like Ms. Swallow, were happy about their outcomes. But the reporter didn't take us up on this offer. Now, turning to the article and the opinion piece, there were 2 main criticisms. One is that Dr. Dearborn does not treat Medi-Cal patients, and 2, the public doesn't have access to the new building. Dr. Dearborn and Dr. Saw do treat Medi-Cal patients, and the reporter was told so by Dr. Dearborn himself and by my staff, but she decided to reference a conversation with the secretary instead. So that there is no further confusion, let me explain the process and assure the public that they do have access to the Institute. Joint replacement surgery is an elective procedure. Prior to becoming a candidate for joint replacement, a normal and common screening process occurs. First, the patient is usually referred by his or her primary care physician. Dr. Dearborn and Dr. Saw are surgeons. Patients don't call up a surgeon and ask for a surgical procedure. Another physician, usually their primary care physician, is the person who makes the referral based on a diagnosis. Patients do not call up an ankle surgeon complaining of stiffness and ask that he or she perform ankle surgery. This first step in the screening process is neither unusual or discriminatory. The second step in the screening process is when Dr. Dearborn and Dr. Saw see the referred patient to make their own clinical determination as to whether or not a particular patient should have a joint replacement. As part of this process, for institute patients, the patient must agree to be part of the research being performed at the institute. In some instances, a patient may not be a candidate for a joint replacement due to clinical reasons, but this is well within the medical discretion of the physicians. Contrary to the implication in the article, a physician does not need to contract with Alameda Alliance to see Medi-Cal patients. Alameda Alliance will pay a physician for a Medi-Cal patient even if there is no comprehensive contract. Now I'll turn to the access issue, which is a two-part issue, patient access and physician access. First, we strongly object to the description of the 6th floor in the article as a dimly lit hallway. There is nothing wrong or substandard with the 6th floor. The 6th floor, like all the other floors of the hospital, is fully in compliance with all licensing requirements. Aside from the 3 patient complaints mentioned earlier, we have received no complaints from joint replacement patients regarding the 6th floor. Second, I want to make a point and make it very clear. The district owns the new building, and any statement, rumor, or innuendo to the contrary is completely and entirely false. However, just because the district owns the new building and the public owns the district, it does not follow that any individual member of the public is entitled to access district buildings as of the member of the public sees fit. As a member of the public, you can't go to the police station and demand access to areas behind the bulletproof glass just because the police building is owned by the public. In a similar way, the district board and management are responsible for managing the district assets, including the new building, consistent with the mission of the district. With that in mind, it is up to management to assign patient rooms. Many considerations go into the assignment of patient rooms, including census, physician schedules, nursing schedules. Management cannot cede control of room assignments to patients or to their physicians. That would result in absolute chaos. Now, with regard to any joint replacement surgical patients, all surgeries are performed in the same operating rooms. With regard to room assignments, we're trying to make rooms inside the new building available to non-institute patients consistent with our obligation for patient care and the considerations mentioned earlier. We indicated that fact to the reporter before the story was written. Non-institute patients have been assigned to patient rooms in this new building. Originally, we had believed that the institute patients would require the use of all patient beds, but while the volume is increasing, that has not happened. So adjustments are being made in room assignments consistent with good management. With regard to physician access, yes, it is true that we decided the institute needed to have requirements for physician participation given the goals of the institute. Those requirements were based on models for other centers of excellence around the country. Any physician who meets those requirements can apply. We require that physicians perform a minimum of 150 joint replacements per year, which amounts to about 3 a week. This is modest by any standard of comparison. Our patient, Ms. Swallow, clearly believes in such requirements for obvious reasons given her experience, and we think other prospective patients will agree as well. And I want to close by making this final observation. I started my remarks by reading a heartfelt letter from our patient, Ms. Swallow, about the wonderful life-changing effect surgery performed by Dr. Saw had on her life, and we couldn't be more pleased. The district created a program, an emphasis on the word program, designed to focus on joint replacement and research with the goal of constantly improving patient outcomes. Based on results documented by Ms. Swallow and other patients, we are confident we're on the right track. As word continues to spread, we believe we will continue to grow our institute. Physical access to a building misses the point. It is about the institute that delivers results. Just ask Phyllis Swallow. I'm sorry I didn't address that earlier this evening, but I think it was important to get it on record. Now I'll talk about the statistics for March. We saw 989 patient admissions. They resulted in 5,474 days of care. The average daily census in March was 177. It was lower than February's, which came in at about 186. The high and low ranged from 208 down to 132. The budget for March anticipated 1,167 admissions were going to be 868 inpatient days of care below budget. Outpatient observation equivalent days were 362. We had planned on 279. So a disproportionately large number of patients fell into the observation category.
362, did you say?
362 compared to 279. Very substantial. And keep in mind the figures in the examples that Chris Henry gave you, and you understand how that pencils out financially. The average length of stay for adults and children in March was slightly lower than budget. It came in at 5.35. We had planned on 5.43. Our preliminary information indicates that inpatient revenue for the month of March amounted to approximately $135,732,000 compared to the budget estimate of $151,464,000. Of this amount, 53.5% was Medicare and 9.8% was Medi-Cal, for a total of 63.3% of government program revenue. Birthing Center saw 162 deliveries in March, compared to the budget of 167, pretty close. A year ago, we had 153 deliveries, so pretty good. In terms of surgeries in March, we had 355 surgical cases at the hospital. We had budgeted 410. I want to make a point. This is the first month in many months that they weren't running significantly over budget. They finally got some breathing room in the OR. This includes cardiac surgical cases that were one above budget at 9. The inpatient surgical activity was below by 74 cases, while outpatient surgeries were above budget by 19. 569 cases were seen at the outpatient surgery center versus a budget of 582, so they were dipping down a bit too. For the month of March, there were 371 cases seen in the cath lab, including 34 PTCAs. Total cath lab cases were lower than budget by 31, and PTCAs were lower than budget by 15. Inpatient cath lab procedures were 55 less than anticipated in the budget, while outpatient procedures were 24 higher than expected. In terms of non-emergency outpatient visits for March, we had 8,598, which was 12.6% lower than the budget. They came in at 1,239 less. Emergency room remained above budget at 4,558 patients, a daily average of 147. Washington, Warm Springs, Newark, Nakamura, and Ohlone clinics saw approximately 3,647 patients in March, 404 less than budget. So the total system emergency room and clinic visits for March are 8,205 compared to a budget of 8,590 visits. Full-time equivalents for the month of March totaled 1,496.9, including 25 agency personnel. We're beginning to import the agency personnel that will support the training program for EPIC. And so you're going to see unusually high numbers of agency personnel arrive between now and July so that we can get our employees trained.
What do you think that number will peak at?
I'm not sure I can get back to you with that.
Okay.
There have been fairly careful budgets developed around that, but I'm sorry I can't quote that chapter and verse. And I would not want to give you a wrong number. But we can discuss the number of people and the agency costs as part of the EPIC budget. I'll get that number for you. So let's see. We had full-time equivalents of 1,496.9. This was 10.4 higher than the budget. The adjusted FTEs per adjusted occupied bed came in at 6.33, above the budget of 5.66. In summary, we had 178 fewer admissions and 868 fewer inpatient days than anticipated in the budget. Our surgical cases were below budget by 55, and cath lab procedures were below budget by 31. Our outpatient visits were 1,239 below budget, while the ER visits were 19 higher than anticipated. Clinic visits for the month were below budget by 404. Total paid FTEs are above budget by 10.4 for the month, 10.4%, and above the last 12 months average. Inpatient charges for the month were lower than budget by approximately $15,733,000, or a 10.4% negative variance. Outpatient charges were higher than the budget by approximately $3,429,000, or 8% positive variance. So total hospital charges for March were going to come in about 6.3% below budget. On March 31st, there were 169 days cash on hand. Total days revenue and accounts receivable at March 31st was 60.35. The days revenue and accounts receivable excluding Medi-Cal was 55.85. During the month of March, $1,754,153 of charges were approved or pending for charity assistance.
Great, thank you very much, Nancy. Do we have need for a closed session?
No.
Okay. Any other items for this evening? There being none, this meeting is adjourned. Thank you.